Welcome everyone. Welcome to the 77th World Health Assembly Side Event, leveraging patient organizations as key partners in the delivery of universal health coverage. I'm WHA77. I'm the CEO of the International Alliance of Patients Organizations. We are a global alliance of patient organizations representing all disease areas across all regions of the world. And we are a non-state actor in official relations with the WHO.
Welcome everyone, and my name is Amanda Bach. I am the Chief Strategy Officer with the Synergist. It's a particular pleasure for me to welcome you in Geneva, where I have many former lives, one of which is working up the hill at ICRC. But I'm also formerly CEO of the European Hemophilia Consortium, and I feel that the rare bleeding disorder community is really close to my heart. And today I bring those worlds together, having the privilege to co-host this with Danny. The Synergist is a nonprofit that builds and maintains the conditions for multi-sectoral collaborations, such as the Global Patient Movement Catalyst, which we will discuss today, and which will hopefully be one of the vehicles to help us with the social participation in universal health coverage.
Yeah, as Amanda said, the Synergist and IAPO, we are co-hosting this side event, and we will be the co-moderators for this evening. And we are very honored with the number of people who registered to be here with us, not only in person, but virtually. We are broadcasting this event, and we had over 500 registrations. We also are very excited about all the collaboration behind this event. We would like to share a big thank you to our sponsors who made this possible. I'm talking about Roche, Boring Ingelheim, and CSL Behring. A big thank you. And also a big thank you for our speakers who are here today, and you get to know them very soon. So today we will talk about agency, and we will talk about the specific role that patient organizations play in the delivery of universal health coverage, but universal health coverage that mirrors the needs and preferences of the people and the communities that they represent. We will also talk about collaboration and how this is the only viable way for us to build resilient health systems. Collaboration and agency is part of the DNA of the civil society, we know well, but we know that this is not the only condition for us to work. We need to create enabling conditions for us to really advance and play a more active role in shaping and co-designing health systems. At the moment, there is so much going on at the global level that is allowing those conditions and that are opening the doors for the social participation of the civil society. It's a historical moment for us. And we are very excited to be able to be discussing this here today. And I wish Khaled Sami, our former CEO, who very unexpectedly passed away last year, was here to see what we are doing and also see physically what we are doing, because this is part of his legacy as well.
So Danny has very eloquently summarized the why that we're here. We would like to say a few words as well as to the how we've organized this. So we are hoping that this can be as collaborative and as engaging as possible in the spirit of social participation, that you feel like you can participate as well. And so we are delighted to have Ia Bricks with us. You can see her in the corner over there, and she is our master graphic facilitator, and she's going to capture the conversations in visual form. So if you learn more visually than you do verbally listening to us, please peer in that direction. We also have a very large participation online, and we welcome our online viewers as well. Unfortunately, we did not have the technical ability to accept questions online, but we hope that you'll make up for it in the room by asking many questions. We would like to start by asking who's with us today. So could I invite you please to raise your hands if you represent civil society? Wonderful, that's a large showing of civil society. Could I ask you to raise your hands if you represent national governments or government bodies? Okay, few for the moment. Could I ask you to raise your hands if you represent the private sector? Okay, roughly equal to civil society. And if you represent a sector, please forgive me that I may not have mentioned, would you like to raise your hand? Academics, WHO, wonderful, wonderful. Thank you so much. So with that, we would like to very briefly invite our wonderful panelists to introduce themselves. We trust that maybe you didn't read their bios. So briefly, if I could invite Mark to start. Please, the floor is yours.
Hi, can you hear me? Yes. I'm Mark Baron. I'm the founder and general manager of the Intersectoral Forum of MCDs in Brazil.
Hi everybody, I'm Pam Cipriano. I'm a registered nurse. I'm president of the International Council of Nurses, and I'm here in my capacity as a co-chair of the UHC 2030 Steering Committee.
Hi everyone, my name is Kira Koch. I am a technical officer at the World Health Organization here headquarters in Geneva, working in the special program on primary health care for immature and social conservation. Thank you.
Hello, I'm Antoine Boivin. I'm a practicing family and community physician in Canada. I'm the co-director of the Canada Research Chair in partnership with patients and communities.
Hi everyone, I'm Laura Bloom, and I'm the president and CEO of the Ehlers-Danlos Society and the vice chair of IAPO. And I also hold a professor of practice appointment at Penn State College of Medicine in patient engagement and global.
Yeah, hi, Brian O'Mahony, Chief Executive of the Irish Hemophilia Society, former President of the World Federation of Hemophilia and of the European Hemophilia Consortium.
And hi, I'm Justin Coonan from Australia, where I'm chair of ACON, the AIDS Council of New South Wales. I'm a former co-chair of UHC 2030, the International Partnership for Universal Health Coverage, and a member of the Political Advisory Panel for the UHC movement.
Thank you, everyone. We would like to start now in setting the scene and why we're doing this and why we're doing this event, and also talking about the value of social participation in delivering UHC. So I'd like to invite Justin to share his experience as a civil society actor, someone who's been representing people with their lived experiences, patients, but also someone who has been participating in so many institutions in key decision-making forums, and who has been really influencing health policies globally. Over to you, Justin.
Thanks, Danny. Thank you to both of you for having us here. Terrific to see all of you here today and online. I also want to start by paying respect to Kawaldi, who of course led this movement, led IAPO, and I'm just thinking back to a year ago when he was the moderator of the forum, just like this one. So remembering fondly. So Danny asked me to talk a little bit about my personal story and background as a way of grounding this discussion, and I will do that. But before that, I just want to make sure we're on the same page when we talk about UHC, when we talk about social participation. What are we actually talking about? So for me, universal health coverage means that all people have access to the health services they need, where and when they need them, without it pushing them into financial hardship. And when we talk about UHC, we often talk about this cube, and I wish I had more fingers, but there are sort of three dimensions to the cube. So the one dimension is who gets covered. Actually, usually it goes this way. Who gets covered? And so here we talk about the spectrum of the spectrum of events which are covered and the populations which are covered. And it's important that we talk about UHC not just in the context of health services that occur in a hospital or a tertiary setting, but across the full spectrum of health prevention, promotion, treatment, rehabilitation, and palliation. So it's really a broad-ranging agenda. So who gets covered? what gets covered. So it's not the case that every government can cover every condition. There's always a situation to find out resources, and so there are debates in every country, whether that's a country with high income, a country with lower income, about what is the spectrum of essential services that are covered. So who gets covered, what gets covered, and then the third dimension is how is it covered? In other words, who pays for it? And this is the dimension really of health financing. Often UHC gets reduced to a discussion of sort of national health insurance programs. And health insurance programs are important, but it's important to remember that that's only one dimension of the three. Another way to think of that is according to the SDG framework, 3.8 is the Sustainable Development Goal around universal health coverage. 3.8.1 is service coverage. So that talks about who gets covered and what gets covered. And then 3.8.2 is financial protection, and that measures the proportion of catastrophic out-of-pocket health expenses, which ideally is smaller, obviously. And if you ask, have we made progress on UHC? The answer is yes. Over sort of since 2000, we've made progress on service coverage. More people are covered than they were at the turn of the millennium. Have we made progress on financial protection? Actually, the answer is no, we're going backwards. And in part, that is because in some countries, well, if there's no coverage at all, then people don't have to spend on it. But in part, so it's natural that there should be some regression as low-income countries move forwards on the service spectrum. But we've seen some worrying instances of out-of-pocket costs escalating. And so there remain 4.5 billion people in the world without access to health services, 2 billion who face financial impoverishment due to their having to pay for financial health for health services. So it is a worrying situation, but it's not a situation without any hope or any optimism. So that's the UHC. We're here to talk more specifically about social participation, by which I would say it means the inclusion of civil society and communities and people and patients in national and subnational health planning. So not just in service provision, the role of civil society and community organizations in service provision is extremely important, but we're going beyond that and saying these people, us, we need to have a seat at the table where the decisions are being made about how that health programming happens. And there are parts of the world where it's done quite well. Thailand is held up as an example with its National Health Assembly. My colleague Kira from WHO will speak much more about some of the details. France has the État Généraux de la Santé, which is another example. Iran has a good example. Tunisia has a good example. But the truth is that not every country had these sort of institutionalized mechanisms of engagement. And what we saw during COVID is that it's really difficult to create the trust that's required for governments and civil society and communities to work together if you don't have these mechanisms already established. So some years ago, I was talking to Kira, I think it was probably 2018, some lovely people, wonderful colleagues at WHO, got together with civil society, academia to develop what became the Handbook on Social Participation for Universal Health Coverage, which is a really detailed guide aimed at member states, answering the questions about how do you actually create these processes, how do you make sure they're representative, how do you make sure that the voices which are least heard become heard, and so on. And following the handbook, some sort of some technical briefs on the topic. We realized that the technical knowledge was out there, but the political will wasn't necessarily, and so some further work went on around developing within member states the political will to implement social participation reforms. And that has led us to this important moment at the World Health Assembly, where we are hopeful of passage on Wednesday of a resolution on social participation in the World Health Assembly. And that's important because once you have an agreed, hopefully consensus document by member states, people in the countries can go back and say, you've agreed to this. You know, patient organizations, civil society organizations can go back, you've agreed to this, how are you going to implement it? So these agreements are not useful in their own, they're only useful if they're implemented, but it's a pretty key milestone. I won't say too much more about the resolution because I know that we have colleagues who will do that. And I will turn instead to something a little bit sort of more personal because that was where I was asked to begin, but how did I get involved in all of this work? And actually, my involvement really is in some ways, or at least it began as a patient. I was born in South Africa at the height of apartheid. My mother was going to be thrown in jail, had to flee, she was unwell, came to Australia, and I had a pretty uneventful sort of first 20 years of my life, but at that point became very ill with something probably similar to chronic fatigue syndrome. But I was out of action for 3 or 4 years, and it was through my own experiences of trying to get better, of meeting the people on the way, that I became interested in health. So all the roles that I've held since then, I've never had any training in health, I've never worked in health. It's simply been because I've understood what it's like to be a participant in a health system and how important it is for people like us to have a say in how that system is run. So I ended up going back to South Africa to work in some of the townships that my mother had worked, and at the time HIV was running through communities, wiping out middle generation. 70% of women testing were positive, and there were no effective treatments and so on. So I became interested in HIV. I'm skipping some steps because I know that I don't have too much time, but ended up doing some youth leadership work when I got back to Australia. I've got grey hair now, but I was a youth at some point. And landed up chairing, as I've said, ACON, the AIDS Council of New South Wales, which is the largest civil society organisation in Australia dedicated to HIV prevention, care support, and also the health and well-being of sexuality and diverse people more broadly. Then one of my mentors who developed Australia's HIV response in the 1980s said, well, you should have a go for this international role. It's on a universal health coverage committee. You'll never get it. They'll never pick an Australian. And actually my first meeting of that steering committee, I was the Civil Society alternate, was in this room. That, I think it must have been 6 years ago now. And one thing led to another. I ended up being the non-alternate, the steering committee member. Then they were looking for a co-chair of this partnership. So UHC 2030, the International Movement for Universal Health Coverage. Pamela will say much more about it. She's the current chair on yesterday's news. They were looking for a co-chair. I ended up, and it's a really interesting model because the partnership was set up as a multi-stakeholder partnership between government, civil society, the private sector, philanthropic foundations, multilaterals like WHO, OECD, World Bank. But they insist on having one of those 2 co-chair roles, one with a loosely government background and one with a loosely civil society background. So I ended up in that role. I've now, I like to call it, moved to the retirement home for former co-chairs. We have a political advisory panel for the UHC movement, which is a panel whose role is to influence high-level decision makers. It's been chaired until now by Her Excellency Maria Fernanda Espinosa, President of the 73rd UN General Assembly. Her term's just rolled off, but I think I can say Marjolaine from the Secretariat might get angry with me, but we've appointed Michelle Bachelet, the former President of Chile and UN High Commissioner for Human Rights. We have Tlalong Mokfokeng, the UN Special Rapporteur on the Right to Health, James Chow, WHO Goodwill Ambassador, and a number of other senior people from a political background at national and local levels. And some random guy from Australia who's never worked in health, but kind of felt that it was important to get involved. And I say this not because I want to talk, I mean, I don't make my stories that interesting, but what I've done throughout my career is insisted that community voices have a seat, not just at the table, but actually at the leadership of the table. And it doesn't matter if you don't think you have the qualifications or, if you say someone else should do it, someone else is better qualified. Well, everyone else says the same thing, then nothing gets done. So perhaps I'll stop, but just to say that the framing of this discussion is that the voice of people most affected is absolutely critical, and we should not be afraid to assert that our role is not to be consulted, but our role is to lead. So that's what I hope I've done. I'm extremely pleased that the UHC 2030 Steering Committee up-leveled in appointing Pamela. but I think that the role of community civil society, but specifically patients, is absolutely critical. So congratulations to Yapo. I look forward to this discussion. I hopefully have some more to say at the end, and back to you.
Thank you, Justin. And I love what you said about having a seat on the table, but at the leadership of the table. That's a very good image, and that's one of the points that we want to highlight here today. I would now like to invite everyone for our panel discussion, where we'll be asking questions to everyone here. And as Justin was talking about the resolution, we'll start with Kira and ask her what is the resolution and why it's so important to have the social participation of civil society in health, and more specifically patient organizations.
Yeah, thank you very much. And maybe I will just pick up, Justin, you had already alluded to it. So this year we have a proposed resolution on social participation for health, universal health coverage and well-being, up for consideration at WHA77. I'm not quite sure, maybe some of you actually have been here last year, a group of member states co-chaired by Thailand and Slovenia, but also with a core group of other countries, including France, Brazil, Norway, and Tunisia, have put forward their intent to pursue a resolution. Now, a lot has been going on over the last year, and this year, hopefully you had already mentioned it on Wednesday, a resolution on social participation can be adopted. We need to see, of course, how it goes, but you asked a very good question. Why is it relevant, and especially why now? So maybe 2 points from my side. The first one, I think, is that the last years has been very much marked by inexorable inequities due to the COVID-19 pandemic, climate change, increased conflicts, etc., etc. And I think COVID-19 has been really a wake-up call for many of us that involving people, communities, patients, their legitimate representatives through patient organizations, civil society is really important in order to better understand the daily challenges, the lived experiences, and how they can actually be used and feed into those decision-making processes so that policies, strategies, plans, programs are more responsive to their needs. So I think this has been very much of importance, but I think we also realize that trust and building those trustful relationships is very difficult during an emergency response. So doing this and investing in social participation early on in order to then leverage those trusted relationships is critically important in service of then another emergency. The second point I wanted to highlight is also, and Justin, you actually had mentioned it, giving voice and agency to people and communities and patients is important, especially if we are talking about reorienting health systems towards primary health care in order to accelerate progress. We heard that the UHC is off track, so how can we actually accelerate progress towards 2030? And social participation can be a very potent tool in order to actually challenge the conventional social norms of who's being listened to, who's being heard, who has influence in decision-making processes. So on this end, of course, patient organizations are a critical, important player in order to bring the voices, amplify people's voices, patients' voices, in order to then co-shape ultimately a health system that is anchored and centered around patients and people. Maybe I stop here. Thank you.
Thank you. And moving from the resolution Pamela, you are now the co-chair of UHC 2030, and the movement has started some years ago, and you have already learned a lot with all the discussions about how to advance universal health coverage. So I'd love to hear from you, so you can tell us a little bit more about the UHC 2030 movement, but also the role of civil society in it, more specifically, and the value of working with the civil society and patient organizations.
Thank you very much. And I want to thank Justin for all of his wonderful comments as well as compliments and humor. So UHC 2030, as you heard Justin mention, is a global multi-stakeholder platform. And the goal is really to accelerate and ensure progress toward UHC. Our members include countries, civil society organizations, the private sector, philanthropic foundations, UN agencies, and other international organizations. What's important is that among these stakeholders, some of the most important ones are our civil society stakeholders. And they are organized and have voice at the UHC steering committee and throughout the work through the civil society engagement mechanism of UHC 2030, the acronym being CSEM, C-S-E-M. So when we say CSEM, that really is the collective of very influential and important voices from civil society. So those voices are really very important. I mentioned to you that I'm a nurse, and I can tell you anytime we talk about changing things in healthcare, the first thoughts go to who do the stakeholders need to be? And certainly nurses always want to be sure they're not left out. But clearly the next group in our minds is where are our patients? Where is the public? How are we addressing their needs? How do we have the knowledge? We may think we know what the issues are, but we may not. We may not have that special information. So one of the bylines that I'm sure that many of you have heard is nothing about me without me. And I think that is really a critical way to think about the involvement of civil society and the voice, particularly of vulnerable populations, in the movement for UHC. We know that our civil society organizations are the ones that have the links to our communities, to the individuals that we want to tap, not only for knowledge, but again, to bring their voices forward, certainly in leadership as well. The lived experience is a phrase that you heard mentioned already, but is finally gaining traction. And in UHC 2030, we want to be sure we are understanding and bringing into the forefront those lived experiences. It's one thing to talk to policymakers and governments about setting the stage and talking about political will. And I'm sure, as all of you know, there is nothing more powerful than bringing forward the story of lived experience. I'll just give you a recent example. I had the privilege of participating in the UN antimicrobial resistance hearing a couple weeks ago in New York. One of the individuals who presented called herself an AMR survivor. For 20 years, maybe some of you saw that online and were there, but for 20 years she battled all different kinds of recurrent infections because of the antimicrobial resistance issues. Her story was probably one of the most powerful statements made during that entire session. And of course, our role there too was to reinforce how important it is to think about the front lines of care, primary health care, as the pathway to universal health coverage. Think about the fact that there's many areas like antimicrobial resistance that don't just pop into your head when you think of universal health coverage. But we also know there's other pieces that are missing within the action plan for universal health coverage. We've talked about the fact there needs to be a set of essential benefits. Well, how many countries don't provide eye care and oral care and a range of reproductive health services and the mobility needs for people? So we know we must gather together the voices and the experiences of everyone to make sure that when we're going to those lawmakers and the influencers, that we are able to bring all of those voices forward. We know it's important that, again, it's not just a patient experience, but it is the community experience. We want to see more care at the family level and at the community level before people get ill. So how do we make sure we're taking into account the preventive needs, the needs of children, the better health so that we have better maternal outcomes for women where that should be a normal experience. And again, it's making sure that our civil society organizations are bringing forward that information. So within UHC 2030, we really rely on those voices and want to make sure that in that dialogue where we do have government leaders, CSEM representatives, other experts, professionals that are in healthcare around that table, then it becomes one where you don't worry about what someone's title is, but you want to make sure you're bringing forward the best information for the policy decisions that need to influence universal health coverage. Something else that Justin mentioned, which is we can celebrate when countries provide more health insurance coverage within their countries, but we have yet to tackle the financial challenges and the poverty that affects people. Remembering again, the three aspects of universal health coverage is be able to have the services that cover the continuum of care that are needed, where they're needed, when they're needed, as well as they must be of quality and they must not push people into poverty. So all of these together, I think, really make a strong case for the need of all of us coming together to make sure that we can influence policymakers with the right information.
Yes, we talked I'm glad to see that everyone is as inspired as I'm feeling here right now, so it's good to hear you clapping. So we heard about the resolution and the political agreement that it translates, will hopefully translate. We also talked about the UHC movement, about the importance of bringing different stakeholders together and how this should be open a door for social participation. And now, if we talk about social participation itself, Lara, and when we talk about it, we talk about people, communities, and civil society. But how does the patient movement fit into these categories?
So I think no? Yes? Very good. So I think it interweaves into everything. You know, so I've been working in this space now for 15 years, and when I started, I was just a patient. And I say that because, you know, we're so much more than just patients, and I'm so grateful that the language is moving away from it being patient engagement, patient expert, and it's much more the lived experience, and I think that's so essential. I come from the rare disease world, and so often it's one person who is out there in the trenches, building organizations and bringing people together when either them or someone close to them, a child, is maybe one of the only people impacted by that disease in the world. And they have to find everything around them and build everything around them. Someone who may have had a career or a very different experience, that becomes their world and they become experts in that. And I think that, you know, the rare disease space is a great platform to look at of how that's worked and how the I transforms into the we, and you bring your story, but then very quickly you start representing the story and the voice of so many, and that comes with such strength, and that can have such a huge impact on getting to a point of universal health coverage. And without it, I think you're missing the narrative, you're missing the why. And I think of your analogy of a table and being the leadership at the table. Well, I take it back a step, and I think people with lived experience need to be part of building that table. We need to be conceptualizing the why, the how, and then thinking about who will be around that table, because it starts with us, and it's more than that, just that narrative of when you're in front of a doctor and living through your health condition. It's your life as a professional, as in education, as a student, as a partner, as a friend, as a child, and all of that comes with experience that is essential to give the why. Otherwise, people are just making decisions on your behalf. And up until this point, it's been tokenistic. It's been a tick box. It's been something that was done, started really in the pharma world, where it was just something that you brought people that had lived with the experience into the end and say, do you agree with this? And oh, we've ticked our box. Very good, now we can move on. And it's progressing in the industry. You know, you now see that people with lived experience are brought on at the beginning. It's not quite there yet. Most times people with lived experience don't get any pay for what they're doing. And I would say when people are trying to build a team of experts, they are seen as equal stakeholders. And we have some time to go before we get to that point. But I would just kind of leave you with that notion of we are so much more than patients. We are experts, and our expertise have just come from living through an experience. And without that, you miss the why, you miss the how, you miss the narrative, and the whole purpose of everything that we're doing.
Thank you.
Thank you. Mark, you as well has a lot to share with regards to your lived experience and also your the active participation that you had in the development of the WHO framework for meaningful engagement of individuals living with NCDs, mental health and neurological conditions. And I would love for you to share, how can this framework drive initiatives aimed at engaging patients in health decision-making?
Yeah, well, first of all, thanks a lot for the invitation to IAPO and the Synergists. It's a pleasure to be here with such a wonderful panel, and I couldn't agree more with Lara's words. Talking about the framework, so I invite everyone who doesn't know the framework, yes, to go online and to check, because it's very interesting. It is a way to do it, to do a guide for the engagement of people living with, in this case, in the case of this framework, with non-communicable conditions. We, in our forum, we try not also to use non-communicable diseases. We prefer non-communicable conditions. But I'm not going to explain this now. But anyway, I'm going to talk a little about the framework that is actually the combination of a 3 years process of informal consultations and co-production. So the production itself of the framework was a participation, was the engagement of people living with the conditions in its production, and it is there were 3 prior WHO publications on the topic also that to get to the framework. So, and it does not only examine the importance of active participation of people with lived experience in decisions that affect them, what we call meaningful engagement, but also outlines the principles and enablers that facilitate such engagement. Among the principles, for example, are inclusivity, intersectionality, while key enablers include capacity building and redistribution of power. And also I should say that some of them are in the text of the resolution that we are discussing. These enablers embody the principles and are essential for achieving meaningful engagement. And meaningful engagement is not just a goal, it is a necessity for effective policy making and implementation. When we talk about inclusivity, we refer to the deliberate and thoughtful inclusion of the diverse voices and perspectives, ensuring that no one is left behind. Capacity building is a critical enabler. It involves equipping people living with lived experience with the necessary skills, knowledge, and resources to participate fully and effectively in decision-making process, in addition to being able to represent their peers, association, and community. Redistributing power is equally important. It is about shifting the balance of power to ensure that people with lived experience are not merely consulted, but are active partners in the decision-making process. Well, the GCM in WHO, with the involvement of a steering group of 9 people with lived experience, which I'm one of the members, is currently conducting a process called Symposium. This process includes meetings and other opportunities for broad participation of people with lived experience, aimed at co-creating preparations for the next year high-level meeting on NCDs. The purpose of the symposium is to ensure that the framework is not merely theoretical, but implemented in practice. We are therefore gathering global people with lived experience community to raise awareness and secure commitment from member states, civil society, and other stakeholders to make meaningful, not tokenistic, engagement the norm rather than the exception. In conclusion, the publication of the framework is a milestone, but it's still an early phase. By working together, we can create a more inclusive and equitable world where voices of people with lived experience are not just heard, but are central to the decisions that affect their lives. Thank you.
So this framework, it sets the guidelines of the value, the importance of engaging people with the lived experiences. And of course, you just mentioned that we need to think now how to implement it. And we have a very good example of how to implement it. And I would like for Antoine here. For a moment, I thought you were just hiding. It is you. It is you. So Antoine, he's a healthcare provider. He's a practicing physician in Canada, research chair in partnership with patients and communities. And in his day-to-day practice, he does engage with the ones that he's caring. So I would love for you to share a little bit about the work that you are doing and what have you learned from this?
Thanks, Danny. Before talking about me, I'd like to acknowledge those people who are not here today. First and foremost, the people who came before us, who cared for us, and who are still caring for us in our communities, our mothers, our grandmothers, our families and friends, who are caring. Sorry. Is it in my head? No? Those people in our communities who are caring for us with or without the help of formal healthcare systems. When I was trained as a family physician, I was led to believe the illusion that I am a frontline provider, a primary care physician, that I am the first point of contact. And one thing that I really liked in your story, Lara, is that it starts with us. When someone succeeds in reaching me in my office, people have started a long journey in caring for themselves with others already, observing changes in their bodies, emotions, seeking information, asking for advice, trying things. So in fact, I'm sitting at the third, fourth, or fifth line of care. And most of the care in our society is in our communities. Social participation, for me, it's not a nice add-on. It's not the cherry on the cake. It's the flour in the bread. It's what creates health. It's what makes it rise. Formal healthcare system is the addition to that. I think there's an allergy between. Is it too revolutionary what I'm saying? Should I stop talking? Is it the physician profession? I can?
Yes, of course.
I don't know. It feels like I'm. Yes? Where was I? Oh, the flour in the bread. Thank you. You've got a picture here to draw. The bread. So what is it about me? About us. So there's nothing special about me. I'm just a plain, regular family physician in Canada. What's extraordinary is the people that I've had the chance to work with for the past 20 years or so, to care with them, to teach with them, and to do research with them. People with lived experience of chronic, mental and physical health conditions, people living with in homelessness, youth living with cancer and their parents, and people at the end of their lives, in their last months of life, who keep on living, loving, and advance and giving up until their last breath. And I've learned many things from them. They've been my greatest teachers. One of the things I've learned is that special knowledge comes from lived experience. The other thing is that wisdom sometimes is forged in suffering. I've learned also that who is vulnerable and who is strong varies, and that both of these things coexist in each of us. That as a physician I can be vulnerable at times, and that patients can be extremely strong because they've lived through many difficult things and can teach us about that. And the other thing that I've learned is that we care much better when we care together as real partners. So that's what I've learned.
Thank you.
Yeah, one.
So I wish all healthcare providers were on the same page as you, but I'm sure there are plenty. But it's very inspiring to hear what about your journey. And you were talking about partnerships and how to work with the ones that you are caring. And I'd love to invite Brian to talk about partnerships as well, but in this case, in decision making and how to engage in shared decision making with the Irish government and how that helps both patients and society.
I don't think Ireland could be classified as a leader in social partnership for patients, but haemophilia is an exception, and we have a strong role in decision making. I think that if many of you would have seen last week that the UK Infected Blood Inquiry reported. They talked about a lack of candour, transparency from government. They talked about a paternalistic model of healthcare. They talked about everything about them without them. They were never involved in decision making as patient organisations. We had a similar inquiry 22 years ago, but in fact we used the inquiry report in a very positive way to make recommendations. And Justin talked about being in the room when decisions are made. We're certainly in the room when decisions are made, and we're formally in the room when decisions are made. By the way, the one word of warning I would say is, to me, the only thing worse than being in the room, not being in the room when decisions are made, is being there as a token presence. So you have to lead, you have to be knowledgeable, you have to train people, you have to send them in fully prepared. They take a strong and active leadership role in the room. Laura talked about building the table, and we did that. After the inquiry report, we used these somewhat general recommendations. We drafted terms of reference for a statutory National Haemophilia Council, which brings together the health ministry, the 4 key hospitals who treat haemophilia, and the patient organisation. Interestingly, like any council, there's a quorum for meetings, but if the patient organisation representatives are not present, the meeting can't take place. So we effectively have a veto. We also set up a formal haemophilia product selection board, which I know made the government nervous because they knew we would insist on the safest and most effective treatments. That was 22 years ago. Since then, we have tripled the amount of treatment being used. We're using the safest and most efficacious treatments on the market. We've been world leaders in introducing new therapies as the first country. And despite that, we have saved the government over 300 million euros because we know what we're doing. And we have increased competition. We have a Hepatitis C Council, which monitors the implementation of all the recommendations in that area. But I think what we've really done is we've moved from patient engagement to patient consultation to participation to a formal role to what we now have, which is co-design. So it's definitely nothing about us without us. A major decision cannot be made on policy or on infrastructure without our agreement, without our say-so, without our active participation. That includes areas like the electronic health record, a home treatment app, a patient portal. It includes setting up and designing and financing a specific ward for haemophilia, a new centre in the second city, and indeed last week working on a peer-reviewed audit where we brought in 6 experts from abroad, which we do every 4 years, to audit our centres and give us feedback on how they're working. So I think we have built the table, we're sitting at the table, we give resources to our people at the table to make sure they're very knowledgeable, and we train them and prepare them well. We actually give college grants to young people with haemophilia when they start going to college, and we keep an eye on what they're studying, and then we bring them through later on, hopefully into positions on these committees.
I love it. I love where this conversation is going to. You mentioned we're talking about building the table, having a leadership on the table, but also not having the discussions when we are not on the table. So making sure that these discussions only happen when we are on the table. So this is amazing. And talking about discussions, Mark, I would love for you to share your experience in Brazil with the intersectoral forum of NCCs and NCDs, where you bring together multiple health stakeholders to influence policies in Brazil and build a more patient-centered health system. Can you share some successful stories with us?
Sure, thank you, Danny. So the forum was started in 2017, and the idea was to create a neutral space to invite public, private, and not-for-profit sectors to sit together and to identify priorities and to develop collaborations and partnerships. So the goal was to coordinate broad, unified actions rather than fragmented efforts, helping Brazil to achieve SDG 3.4 by 2030 through the collaborative power of SDG 17. So since its inception, people with lived experience participate in the forum. We call Forum CCNTs, the acronym. Participate from the foundation of the Forum CCNTs to the advisory board, the different activities we do, the working groups. Nowadays we have 10 different working groups active in the forum. Today it stands as one of the largest multi-NCC, intersectoral and multi-stakeholder initiatives in Brazil, with over 200 actively participating institutions from the public, private, and civil society sectors, including also medical societies, academia, and multilaterals. As a result, we have been able to positively influence programs and policies across the country. We integrate knowledge from academia and medical society, as I said, and solutions from public, philanthropic, multilateral, and private sectors. One notable recent achievement has been addressing the issue of sleep disorders, a risk factor for many non-communicable conditions and their complications, which was previously overlooked. This year, our recommendation to include sleep disorders as a risk factor on par with traditional risk factors in the National Clinical Protocol for Type 2 Diabetes was accepted. In addition, questions about sleep disorders were for the first time incorporated in the National Surveillance of Risk Factors for Chronic Conditions. And the largest city in Brazil, which is São Paulo, where I live, is currently launching a program for screening, diagnosing, and treatment of sleeping disorders. So this is just one example of our achievements. During COVID-19, for example, we published recommendations for vaccination prioritization that health authorities found useful for their decision. Additionally, we have made significant strides for the incorporation of new technologies to improve cancer control programs and facilitate partnerships for scaling up successful programs in primary health care initiatives for hypertension, diabetes, COPD, among other chronic conditions. In conclusion, the Intersectoral Forum of NCCs in Brazil has made significant progress in fostering collaboration across sectors to address NCCs effectively. By unifying diverse stakeholders and prioritizing comprehensive coordinated actions, we continue to drive positive change and work towards our shared goal of achieving SDG 3.4 by 2030. Thank you.
We just heard very practical examples of the value, but also ways of including the patient voice. And taking all of this in consideration, Kira, if the resolution on social participation is adopted at the WHA, which we hope it will, what are the potential pathways and mechanisms it may offer for inclusive participation of patient organizations in decision-making processes to advance UHC?
I go for the safer microphone. Thank you very much. And to your question, yes, of course, the potential adoption of the resolution is a critical milestone. But I think we also have to be clear that first and foremost, it's a piece of paper. So the real challenge is to bring this to life. And for this, we need all actors in order to implement meaningful social participation. So there are, of course, a lot of opportunities, a lot of mechanisms, a lot of examples that many of my speakers here on the panel have already shared. And I think what I like to highlight is that there can be various parts of which social participation may take on a form. It might be a large-scale public engagement mechanism in order to deliberate with the public on a specific topic. It might be a citizen jury, deliberative forum. It might be consultative meetings where specific civil society or patient organizations are coming together with governments in order to discuss or others in order to do it. I think importantly, when we look at it, it's a mix of mechanisms that you want to use in order to reach broad and diverse voices, in order to ensure that you understand the different challenges, the different needs, the lived experiences, and also some of those groups that you may not be reaching at first. So doing this additional effort is also very much important. We've put forward, and this is also reflected actually in the WHO handbook on social participation, key priority actions. And this is very much in line actually what we've been just hearing. I think besides actually within civil society, training civil society, I think it's also important that we need to reflect and work towards investing in government capacities on how to actually do social participation. And here it's the added value of social participation, understanding actually that there are power differences, and as you have just mentioned on how can we actually be an active player, understanding that we need to mitigate power imbalances, that we need to address any potential conflict of interest in order to create those safe spaces, as we would call them, where everybody is empowered as much as possible to be at that equal level in order to contribute meaningfully and influence those decisions. So we are moving away from this tokenistic, we have the one or two civil society representatives, but we really have a possibility, everyone around the table, in order to influence. The second point is to ensure equitable, diverse and inclusive participation and representation. So who is actually at the table, and more importantly, the question who is not participating, and then reaching out to those that you have not reached in the first place. The link, my third point, on policy uptake. Again, there are many participatory processes in countries that are taking place, but it's also important, and this is actually the critical challenge, is how these results then are also meaningfully and adequately taken up when it comes to decision making. We talked about the adequate, stable and predictable funding and financing for those social participation processes. We reflected already on the capacity building and coalition, the importance of bringing civil society, training them, having them there in order to meaningfully contribute. My last 2 points maybe is also to move away from the ad hoc and one-off events to really embed it within the health system as not, as you mentioned, as an added on, but really as part of how we envision an inclusive governance for health. And this certainly moves into how to institutionalize social participation, how to embed it in order to make that regular and sustained engagement over time. And in order to improve it, I think it's also important, and this is my last reflection, is on how to monitor. how can we actually assess that engagement is meaningful? And we are working a lot on this area because it has not been much attention on how we can actually measure representation, capacities, policy uptake, etc., in order to understand and use it as a learning opportunity in order to refine and improve those participation and meaningful engagement over time. Thank you.
As you well said, the resolution is going to become a political agreement, but then implementation time, that's when the challenges will come. And Pamela, I think UHC 2030 can share some learnings that you have from the engagement with the member states or the governments and how they're implementing UHC and how they are engaging civil society in UHC. And can you please share some learnings and stories with us?
Well, we're obviously all hopeful that the resolution will pass. Because I think what's most important is that we realize that the work that has been ahead of us and it is an active part of what UHC 2030 is working on is really implementation of a strategic framework to make sure UHC happens. And part of that is the monitoring and reporting about the progress. Now, we don't do that alone by any stretch, but we have a significant role in terms of understanding the levers that need to be flipped or pushed in order to be able to help governments in their work, civil society organizations as they influence the processes, and again, any other group that really believes that they have a stake and are stakeholders. Because we know that accountability is one of the things that is often missing when these major pronouncements, political declarations, resolutions are adopted. Some countries take them very seriously, and others check the box. And so I think that, again, that's sort of one of our roles, is to make sure that we engage not only our political advisory committee, who wants to be very active in this space with us, but also be able to put on the table more strategies for how we can encourage the uptake of what's in any of the pronouncements or resolutions. So in this case, our civil society engagement mechanism group has 1,500 members in 100 countries. That's a lot of great voices to mobilize. So as we've seen the CSAM influence be effective in many areas and be able to, again, push the agendas, I think that's really one of our charges going forward, which is how do we utilize the enthusiasm and the people power that's represented in the civil society groups, because obviously they are already engaged in understanding and accepting a role in advocacy. So I think our big push will be looking at how do we do that? So how do we actually send the message without being offensive that we're going to be watching for accountability, and we're going to want to monitor and measure to what degree are we seeing that civil society engagement. I think the other piece of monitoring is to be able to encourage civil society groups to feel totally liberated. The barriers shouldn't be there now. If this resolution passes, it is calling for stepping up, bringing that voice forward. Again, it's probably easier said than done, but recognizing that it does put a stake in the ground to say this is an important part of being able to move all of these agendas forward. And it is an expectation that not only those groups that have held the power welcome in civil society groups and social participation, but being able to say we really want that active participation, and there should be no barriers in making that happen. Again, it'll be different phases, different rates of uptake in terms of a variety of countries that we work with. But I think it's important that for our role, we can be the ones that push on, here's the provisions in the resolution. Here's what you said you were going to do when you raised your hand and said yes. And so again, I think bringing together the accountability for the provisions in the resolution, the commitment to social participation. We want to work hand in hand with these 1,500 civil society groups and more in order to be able to say we're going to put teeth in this resolution. Again, I don't think any of us wants to be cynical, but we do know that there are many things that we can look back and say, we've been doing the same thing for 10 years, or we've been pushing the same idea for 20 years. We don't have time for that to happen. And maybe the urgency of the year 2030 will get under people's skin, and there will be some additional emphasis to say, we are behind on reaching UHC goals. We must move together as one, because that's the more powerful as well as the right way to go.
So Brian, what are the arenas and forums that can really allow this participation, that can really allow the transformation to occur, and that social participation is effective?
I gave the example earlier of the National Hemophilia Council in Ireland, and that has moved the needle for us insofar as we don't really advocate to health ministers anymore, to officials. We walk with them. So we're not advocating for a policy, we're in the room recommending the policy. That's a paradigm shift in the way things work. Some international examples, the European Hemophilia Consortium, a couple of years ago, we were very concerned that a lot of countries in Europe were paying prices which were too high with medications. So we sought countries to agree to a 3-year procurement model. The governments would agree to a 3-year procurement model. In turn, the industry would agree to lower the price to below a ceiling price, about a 70% discount at least on the current prices. And what that did, that changed the market to an extent in some countries when they started getting lower prices. So that was successful, even inadvertently. The World Federation of Haemophilia did a program called GAP, where they tried to build sustainable care in the country by making it attractive to treat haemophilia. So they went in, they did training with laboratory scientists, with doctors, they twinned the centres and the patient organisations with those abroad. They did training for the patient organisations. And crucially, they gave donations of medication to prime the pump, but then the countries also had to set aside their own budget for haemophilia treatment. What it did was it added huge value to the budget they had, and it made it a win-win situation. Another example are what I call circular advocacy. So in many countries in Europe, you'd be looking to go to your ministry and you'd want to advocate for something, but they'd want evidence. So we would do detailed surveys of every aspect of haemophilia care in a country, and then from all those European countries together, we would go to the European Directorate for Quality of Medicine and Healthcare meetings. We would use that data to push for the recommendations. The data was very useful in getting those recommendations. Then those recommendations would be approved by the Council of Europe, and then you could go back to each country and say, it's not just us saying this, it's the Council of Europe. So there's almost like circular advocacy. One example, I think, which I hope will change is the current iteration of the World Health Organization Essential Medicines List has been regressive in terms of they have added in an old unsafe therapy for haemophilia, which we're trying to change. And I think, unfortunately, I think the reason that happened, they didn't have haemophilia clinicians or patient organizations consulted in the decision. So the decision was made about us, but not, totally without us. So I'm hoping that will change.
So many opportunities out there that we can learn from. And Antoine, I would love for you to share, how do you see patient and community partnerships contributing to better access to care? And for you to talk about your practical experience on that.
I have your microphone.
Thank you. I think we need to take the long view to reflect on impact. So like Justin, I look young, but I started medical school in 1996. It's almost 30 years ago. Back then, the medical students, my colleagues, we wouldn't even believe the psychologist who was teaching us mental health. It needed to be taught by a physician. And currently in the same university where I trained are 250 patients acting as teachers to medical students and healthcare professionals. They're teaching every year 1,400 future healthcare professionals. Now this is change in action. in our healthcare system. Now there are patients everywhere in quality improvement, in clinical practice guideline development, in policy making, on the research team. It's something I'd never seen when I was a medical student. I've seen this in a lifetime, and I'm still young. This is changing, and it's not new. You know, the barefoot doctors in China dates back to the 50s. Community health workers, it's been experimented on for decades in many, many countries around the world. Peer support, it's been going on since the 19th century. Self-help, mutual support, all of this, it has long history and long impact. For me, what is new and is meaningful this week is the recognition that this matters by international government around the world, that there's no health without people engaging in it. And for me, it makes a difference. So for me, this resolution this week, it matters for 3 reasons. First, because there is international recognition of the value of social participation in health, that this is a core component of health ecosystem, not just the nice cherry on the top. The second thing for me that is really significant in this resolution is that it starts with those people that are not at the table, that we do not hear, those people who are excluded, that we cannot progress on universal access to health if we don't learn from those people who do not have access to health, because they are the people who know best which are the current barriers to accessing health. Access to food, access to water, access to shelter, a safe environment, access to basic health care without discrimination. We need to, more than broaden the table, for me, we need to, the other thing that I like in the resolution is that it's not just principles and nice words, it also comes with requests to the Director General of the World Health Organization, and it pushes on member states to move from rhetoric to action. It's very easy to be in favor of the principles of social participation. It's hard to move towards action. It's one thing to give voice to people. It's another one to listen and to act upon what people say. It's one thing to offer a seat at the table. It's another one to share power. And it's one thing to struggle one against the other in the stakeholder groups. And it's another one to work together, to join forces in advancing toward health for all.
Talking about action. Talking about action, Lara, how we can catalyze the global patient movement and create conditions that can accelerate the inclusion of patients in health decision making and really advance universal health coverage.
So I think it needs to come together much more and become streamlined. And a couple of years ago at the Patient Engagement Open Forum run by Synergist and PFMD, there was all of this great conversation coming together, and we realised that a movement was starting. And a lot of people came together, and over the past year, Amanda's been leading this patient movement catalyst, which is focused on 3 pillars, which is about capability, positioning, and funding. And I'd like to kind of say this is a very embryonic concept, and I invite people to get in touch with us and get involved, because we want this to be truly collaborative, truly global, bringing in as many different experiences as possible. Because, you know, we've talked about education, and I think education is a huge piece of it. Medical students, I have the joy of lecturing to medical students, and I ask them the question, you know, what does patience mean to you? And sometimes they turn around and say data, and I realise how far we have left to go. And you think that we've come some way, but actually it's quite painful how bad things are. And then even more, I think, challenging is to re-educate people and actually let them know what it truly means for it to be nothing about us without us, because there are generations out there that believe they know what that is, and they have it very wrong. So education, re-education. And I think if we truly allow this movement to come together, for it to be consistent, for the terminology to be streamlined, for it to be global, for it to include everybody that is living with these conditions to be part of that, then we may actually get to a time where geography, wealth, gender and race don't determine our quality of life in the way they do now.
A huge thank you to all of you for your insights and for sharing your experience. And this was very inspiring. But I would love to now hear from Justin and listening to all that those incredible panelists have just shared, how these experiences resonate with you, with your work and the journey ahead for the patient community.
Thanks to the wonderful panel and to Danny. The first thing I want to say is that another aspect of my personal journey is I have a visual disability. I can't see that far into the audience, but I have just seen that we've been joined by Mariam Jashi, former Deputy Health Minister of Georgia and now CEO of the International Sepsis Alliance, and one of the terrific advocates on the UHC Movement Political Advisory Panel. So I want to acknowledge Mariam and thank her for being one of those very powerful advocates. In terms of what we've heard from the panel and how we move forward, I think the reality is we're speaking to the converted in this room, right? You're not in this room if you don't agree that social participation and is important, and the role of patient organizations is important. And what I've picked on from hearing from many of the speakers, and also my own reflection, it's important to get concrete now. Concrete means, first of all, concrete about the value of social participation. I like what you said, Antoine. We're not the cherry on the cake, we're the flour in the bread, or maybe the flour in the cake. But I think we need to be really confident about the evidence that we have that social participation works. I mean, if I reflect in my own country's situation, at the beginning of the HIV movement in the 80s, in the 90s, communities were affected and were included in some very bold ways. You know, it wasn't easy for the government to partner with men who have sex with men, with sex workers, with injected drug users, but they did. And we're seeing now the fruits of 4 decades of that engagement. In inner city Sydney, where I live, we're this close to eliminating HIV transmission, and that hasn't happened in many parts of the world, and it's attributable to the way that communities have been encouraged to take care of their own health from the beginning. So we need to be really concrete about the evidence and confident about the evidence that this is just a nice thing to have, that it works. And we also need to be concrete about the next steps that we take. And so here are 2 tiny next steps you can take, especially for those of you from civil society organizations. Of course, we want to see what happens with the resolution, but if you want to hear what happens next, number 1, you've heard a few times about the civil society engagement mechanism for UHC 2030. That is the civil society mechanism to stay in the loop with what's happening in the social participation space. The website is csdemonline.net. You can join with no obligations as a member, do that, and you will hear what's happening in terms of implementation. The other thing I know you wanted me to mention, Danny, but in parallel with this work around how we empower member states to engage civil society and communities and people through social participation mechanisms, we also need to empower and capacitate multilateral organizations, particularly WHO, to support this work. And so you may or may not be aware, but there is a new WHO Civil Society Commission that was launched, I guess, about a year ago now. I want to acknowledge my fellow steering committee member, John Coughlin, from the International Cerebral Palsy Alliance. That is another mechanism, because if the multilateral organizations, if WHO can't do civil society and community engagement, well, how are the countries going to do it? And let's be honest, and block your ears, WHO colleagues in the room, but I think some parts of the organization do it really well, some parts less well. So we need to capacitate WHO and the institutions as well. So, point 1, join CSEM, the Civil Society Engagement Mechanism. Point 2, sign your organization up as a member of the WHO Civil Society Commission. It's a formal mechanism. There's a bit more of an involved process, but it's worth it. Those are my 2 concrete steps. My first point was be concrete about our evidence and confident about our evidence, but I'm confident with the people in this room that we're ready to make progress once the resolution lands. So thank you.
Well, thank you so much for those words. I was meant to do the closing takeaway remarks later on, but I kind of feel like you already made them, but I might remind people of what you said. We promised that we would be interactive and engaging. Time is running away from us, but we want to hold ourselves to our promise. So please, anyone in the audience, a microphone will come to you shortly. I see someone in the back, and 3 in the front. Oh, wonderful, 4 in the front.
So the question is about the not about us without us with regard to funding. So there are difficulties in funding, and so how are the solutions sought, and are patients involved in that search for solutions for funding?
Can I note very briefly that as part of the one paragraph in the 2,500-page UK Blood Inquiry report states that the funding from the government should now be provided to the haemophilia, thalassemia and sickle cell organisations in the UK, which has disgracefully not been done in the past. So I think government should fund this. They should fund the participation of patient organisations in this space.
I might add to that answer that this draft resolution itself includes funding mechanism language, so even more important to support and rally support around it being adopted. And the funding exploration is also part of the work that we're trying to do in the Global Patient Movement Catalyst, because funding, and especially core funding, is such a problem for all patient organizations. And if we want to show up as part of the solution, we have to be able to do so.
I'm not talking about the funding of the participation of patients. I'm talking about the funding of the universal health coverage.
Okay, so I'll just repeat for the viewers online. The question regards the funding related to the universal health coverage itself. So this, I would perhaps invite Pamela or Justin who wants to take the floor.
In general, I mean, that's a policy advocacy process. And so that really relies on everyone and every group you're part of to actively be an advocate and to lobby, I mean, depending on the capability and the limitations that you have in your role and your organization. But I mean, those are the big B budget issues within every country. Or I mean, there may be additional levels at your community level, and depending on how your geography plays out. But most countries start with some kind of overall funding of the health system, and again, that's where the influence has to come. Is there a set of universal benefits, and does that need to be increased? Does it need to be changed? Does it need to be more refined? What is the government able to provide in terms of coverage for medications? How comprehensive are the services? Is there access to things like testing and vaccinations? I mean, it's really looking at what is in the budget. It's a very it's purely political process in terms of this resolution doesn't give you any more authority or any less authority to go and lobby for the better funding of healthcare. The UHC platform, though, has already called on member states to increase the percent of GDP invested in healthcare. So that is a constant discussion right now. And of course, in some places it falls on deaf ears because there are many financial challenges that our politicians are facing. Some want to deal with it, and some, will say it's almost impossible with the competing interests. But again, I think it's the activism within each of our countries that will make that difference. And again, we obviously, everybody here believes that we have to keep pushing for greater investment in health.
Thank you. There are so many questions on the front. Gentleman in the middle, please go ahead.
Yeah, thank you. My name is Shola Shogari. I have two affiliations. First, I'm a Nigerian from the Global South, and secondly, I'm a member of the International Federation of Pharmacists. I came here out of curiosity to find out what Apple is doing. My gosh, I must say you're doing fantastic work. Okay. And I came because I had an experience in engaging the healthcare system in my country about 20 months ago, when my dad had to do hip replacement surgery. He spent 20 days in hospital, and the treatment he got, was below par, to say the least. His privacy was not respected, his dignity was violated, and I thought, no, we can do better than this. And I saw the need for a patient advocacy group. I thought they were not present in Nigeria because I just met someone today, Rachel, who told me they have 1 or 2 representation in Nigeria, but a lot more work needs to be done. And I want to plead that you extend more of your work in Nigeria. It's not about money, it is about being mindful of the need of patients, of the need for their privacy. Because we come from a history of respecting and fearing the healthcare system. So we need to empower patients, and we need organizations like yours. Secondly, I want to speak to our definition of patients, given the changing landscape of the healthcare system. I'll mention three metrics that are affecting it. Primary healthcare, it's been with us forever. There's self-care. We're beginning to have a lot of very, very sophisticated devices that patients have access to, and that are dishing out data practically on second by second basis. Your blood pressure, your blood sugar, pulse rate, oxygen saturation level, all can be measured by devices, and empower patients. Okay. The third thing is the complexity of therapies that that are coming into the market. Now, like I often tell people, you can find a product that will have a software, a drug product, and a mechanical device all in one therapy, quote and unquote. It's becoming very, very challenging even for pharmacists who are supposed to interface between these products and the users and the healthcare providers. So basically, the point I'm trying to make is that there are people who will engage the healthcare system only once. That's at the point of diagnosis and the prescription of initial treatment. And for the rest of their lives, they are practically just interacting with the pharmacist to manage their medications. Are we advocating for them? Have they slipped through the crack? I want the panel to speak to that. Thank you.
Thank you. I wanted first to thank you for bringing a Nigerian perspective to the conversation. One of the things that made me uncomfortable throughout the discussion is that we're a very white panel coming from the global north. And that reflects many of the academic conversation or scientific conversation or professional conversation about engagement. It tends to be within bubbles. One of the things I was excited about with the resolution is the opportunity to open dialogues and to learn from one another. I like the way you talk about your own experience and what we can learn from it. And for me, engagement and partnerships are not like medical device that you can design in one country and export into another. For me, there are living relationships that are shaped by the communities in which they grow. So although the principles of gardening can be exchanged, the listening, the time, the patience, there is a certain craft that is really local. And I truly believe that we can really learn in many directions. So in terms of concrete action on Thursday, I'm concerned about Thursday, not Wednesday. Wednesday is for the politicians. Thursday is about us. What are we going to do with this? I believe part of the action that we need to take is to start to translate the language of this resolution, which is very opaque, and communicate it in our community so that people understand that it concerns them and that we can start rallying around these principles and work together a little more.
Thank you. We are already over time. We're going to go over time by 5 minutes. I'm looking to Danny by 10 minutes. Sorry? 15. Okay, we'll go over time by 15 minutes if that's okay with all of you. If we don't get to you, there is a dinner. You're all very warmly invited to join, so you can ask your question then. I beg of you, please, keep your questions short, because there are many of you with hands up, and keep your responses short as well. Then we'll get through more of them. So please, next question.
Thanks very much. Great panel. I really appreciate all your perspectives. I think, and I love the idea of like, where is the front line? Really, it's not where I'm a paramedic care provider as well. So, but I'm thinking about one concrete step that could be helpful, and it's just from Margareta Langen. She's a Canadian nurse who works with WHO Europe. Wrote a great paper several years ago about competencies needed to advance integrated people-centered health services. And it wasn't typical. It was very hard to understand at first, but she drilled down to even the competencies that patients need to have to be able to know how to understand their health systems and navigate health systems. And that includes people with lived experience who are going to become the advocates for that. So I'd say one thing that we could start with is trying to make sure that patients actually understand, are competent, we work with civil society to educate patients, to enable them to be competent in how to understand and manage the health system. That's the way we then can only empower them to be advocates, in my view. And I work in primary care at St. Michael's Hospital in Toronto. And we actually surveyed our patients, and we have a patient advisory committee, and asked them, tell us, what is primary care? And they have no clue about what primary care is. And yet we're transforming it. But they have no understanding of what it is. So I think there are some very basic elements we can actually start with working there. Any comments?
Thank you. That was a comment. Any quick responses?
I think in the NVIDIA field, therapy has become so complex, everything from plasma-derived products to gene therapy, that you have to have shared decision making. The patient has to be involved in the decision. Gene therapy is a one-off, irreversible therapy. So that means we have to educate the patients to take a full part in their own decision making and in their own health.
Thank you. Next question.
Yeah. I'm Wolf-Dieter Trede of the International Association for the Study of Pain. I came here because we're also advocating the field of universal health coverage, NCDs, and we work with patient organizations. However, my comment is not about all the wonderful things that I can relate to, but to your question about funding. It seems to me that in this room not too many people are aware of the investment round that the Director General has started. So we cannot look at the countries. The countries voted last year to increase their contribution by 20%. It still makes up 1/3 of what the Global Plan for Work calls for. And it used to be that foundations like AIDS Foundation funded things, but then they kind of directed the activities to certain fields, all of which were fantastic, but other fields are left out. And I think if anybody can help the Director General to spread the funding more evenly, it would come from your group, because at this opening event, I think the movie is shown from the lived experience part, but there was not such a strong presence of patient advocates. So if you haven't done so already, I would suggest that you offer your advice on evening out the use of the funds and also helping to gather them by showing the stories of lived experience.
when I had this wonderful opportunity to be in Geneva. This is my third event of the day, so it has been a busy day, but I wouldn't miss an IAPO event for anything. I've had some very good sentiments. I'm impressed. If the language of nothing about us, without us, has reached where a professor is, then I think we are halfway there. Because it's very important that this is understood at the highest level possible. I'm very impressed with what Brian has talked about, what's going on with the hemophilia community in his country. And what is also going on in Canada with patients being part of those teaching the health professionals. And I think we need to leverage the voice of the patient and to bring them not just to the table, but even where the action is happening. Patient needs to get there. If we don't facilitate the patients, we're going to have these kind of forums and talk about meaningful involvement, but if they are not facilitated, if they are not capacity built to be able to repackage their message and tell their stories, it's not going to happen. And I'm going to tell you one of the reasons why, like, you may not have a lot of patient representatives here today. A lot of forums and activities around health are usually funded by pharmaceutical companies. There is an ethical requirement that these companies do not engage directly with patients. So they will not be comfortable, for example, funding a patient or a patient group to an activity. And we must help these institutions to navigate that barrier, because there are ways of going around that without violating their ethical requirements. If we do not help those organizations, those institutions to navigate that very, not very comfortable area for them, then we are not going to have a lot of funding happening, and we're going to have more forums where actual patient participation is missing. Finally, Justin, I recall what you said about UHC, particularly UHC not being part of national insurance. In my country, we did that. We experimented with UHC. We started an experiment with 4 counties, but we called it a pilot project. When the results came in, we looked at the numbers, we said, if this is the cost for 4 counties, and we have 47, we will never afford UHC. So what the government did then, that was scrapped. It was the best UHC moment for us, because in those 4 counties, you went to hospital, you were diagnosed, you were treated, no out-of-pocket expense. It was said to be too expensive, so they did it, and it was lumped into our National Health Insurance Fund. Now, the National Health Insurance Fund is a private members club because you have to pay a fee. So the universal element disappeared. But people had heard the good news of what UHC is. And so when NHIF started carrying the UHC tag, and it was not being universal because not everybody could access it because it was for members. Do you know what has happened to NHIF in Kenya? It has become bloated, and we are actually replacing it now with what we call a Social Health Insurance Fund, where now everybody is welcome. And because not all people can afford to pay for health insurance, we have different bands, and those who we call indigent, who cannot afford to pay for it, the government is going to pay for them. So that it's universal health coverage where everyone is paying or being paid for. So for us to be able to continue with all these stories and having this engagement, it is good to share some of these experiences, both for parents, patients, both for the countries and what they're going through, so that we can still get a better chance to leverage patients as key partners in the course of the universal health coverage. Thank you.
Thank you very much for that very rich contribution. There's a question in the back. I'm just going to move on to that, please.
Hello, I'm Krista. I'm a sepsis survivor from Belgium and patient advocate for the Global Sepsis Alliance. I love to hear you saying that we patient experts are the flower in the cake. But I was wondering, where one of the biggest challenges not be a shift in the minds of decision makers, of healthcare professionals, because we patients are usually not seen as experts at all. So I was wondering, do the panelists have any ideas, concrete ideas, suggestions how to deal with this?
I think it's important to recognize that it's a shift in our worldview and a shift in culture. So changing institutions, laws and regulation is one thing, and it's very important. But if we want care to change, we also need to change people's mind. And that includes the mind of healthcare professionals, like me, recognizing that, the patient in front of me knows better than I do on many things. How do you live with your illness? How do you spend your day? What are your dreams? What are your goals? I don't know, really. So it's a shift of culture, and that takes time. And this is also why I think we need to re-anchor ourselves also in the longer view.
Wonderful. I was going to wrap up, but Kira, I'm very happy to give you the last word.
Thank you very much. Quickly on this point, I had just 2 points. I think I like always of universal health coverage to think of a goal, an aspiration where we want to come, because it's really a noble goal of leaving no one behind. And we have our means within our health systems, with our approach of primary healthcare. I'm very much agreeing on having the capacities also to understand what we actually mean by that. To your point, and maybe quickly on this, 3 points we would point forward, and I think it captures quite well what Antoine just mentioned on the capacities. We would call 3 main capacities. One is the recognition skills, the understanding of the added value, to understand that we need that paradigm shift. And this means changing power imbalances. First of all, recognizing, acknowledging that they are, and then mitigating those. And this is not something that can go over time. The second one is on technical skills. How do I actually, in social participation, do I organize a meaningful participatory process? I need to think through representation, inclusiveness. I need to think through how I can actually adequately improve policy uptake, and all of those difficult questions. And the third one is communication skills. And this is also, again, something that we heard earlier on, what does it mean to translate and providing neutral, factual information to participants of those participatory processes, so they understand, they can prepare for it. Doing this also in ahead of time, so there is time, because often all these are volunteers. They also have their daily lives. They need to find time in order to then prepare adequately for it. And for governments, and also for researchers and for WHO, it's also about translating then the lived experiences, listening and translating them into policy relevant solutions, recommendations, doing this jointly. So I think a lot on the communication is also there. Thank you very much.
Thank you, Kira. And I stand corrected because there is one last question that has been out from the floor. Please, floor is yours.
Thank you very much. So let me introduce myself. My name is Neelam Chingra. I'm the head of patient safety flagship at WHO headquarters. And I really want to thank Dani and our colleagues at IOPO for inviting us. And my team is here, Irina and Ida. So the 3 of us are really, really interested because it's absolutely music to our ears. We have, a program on patient safety, and I'm very proud to mention that IOPO actually, the partnership IOPO with WHO sits in our unit. So we are very happy to have this ongoing collaboration for several years, and excellent panel and leadership of IOPO. And I must mention a couple of words which were mentioned, and I just want to reflect on some of them. One was elevating the voice of patients. For WHO, World Patient Safety Day has provided a great platform for providing opportunity for patient engagement and enhancing knowledge about need for safe care. And so last year we had engaging patients for patient safety as the theme for World Patient Safety Day. And very proud to mention that we launched a patient safety rights charter, which actually elaborates really what are the rights of every patient to ensure safe care. And so I look forward to IOPO actually implementing it.
In addition, we also have a global patient-centered action plan which was adopted by the World Health Assembly in 2021. And just reflecting on Pamela's point about monitoring and evaluation, we actually have a mandate to report to the World Health Assembly every 2 years. So we reported last year, and we're actually going to launch a global patient safety report this week itself. So extremely important to have patient engagement, and we have extremely specific strategies as well on patient engagement, plus indicators to report, particularly one on how many hospitals in a country really have patient representatives on the governing boards so that they're contributing directly on engagement and having a platform at the leadership table. My question is, to the panel members, is that in your opinion, what are the most effective strategies to bring about patient empowerment? So I'm moving ahead from patient engagement, participation, involvement, but more empowerment and shared decision making. So we have a couple of strategies which we have defined, but I would like to know from your experience, what are the most effective strategies for patient empowerment? Thank you.
Neil, I would say one of them is for patient organisations to identify, train, motivate and empower people in their own country. So you can't, as a patient organisation, you can't really be involved in decision making if you don't have the people who put the work in to do that. No point in going to a room and sitting quietly at the table. So I think training by patient organisations of patients within the countries, and ideally government support for that in every country.
Just adding very briefly, to me it's all about when. So it's when that lived experience is brought in, and too often it's too late. So right at the beginning, when every other expert is brought together, that's when it should be.
If I could just add something as well. So in Brazil, we also published a model that we, well, after almost 10 years of training young leaders in diabetes for being advocates and leaders. So we built the empowerment ladder. It's published, but for us, it's important that there is a mentoring program that people with lived experience that have already passed through the process of contributing of meaningful engagement, that they are also able to prepare the next generation, the other ones to collaborate to engage.
For me, what's the most impactful is not the talking. It's not even the science, and I'm a researcher. It's the experience of it. And that means the experience of becoming a patient. That's probably one of the things that had impacted most of it for me, is becoming a patient. But also the experience of working with patients as colleagues. That shifted my view of the vulnerable patient becoming a strong person that I can lean on at times. That's experiencing.
So I had prepared a really nice introduction and text about someone very special here today, who is a big champion of patient engagement, but then she came up and started talking about her work and the amazing things that she's been doing the past years. Because today we really wanted to take a moment and celebrate Dr. Neelam, because she's retiring from the WHO this month. She will stick around, we'll continue to collaborate, but she's been a very special advocate within the WHO to really bring patients into its structure, and we wanted to take a second and give you a small token of appreciation for your work.
Okay, this evening I've been given a small task to recognize the outstanding, special, exceptional leadership which you have made to Ayapo. Dr. Nyam, we are told she's retiring, but not retreating, hopefully, since there are so many advisory roles to take within WHO or even for us patient organizations. Dr. Nyam steered the development, implementation of the Global Patient Safety Action Plan. And what is more critical in that plan is that there is a whole chapter where patient engagement has been formalized. This is a very, very significant move which has moved several nations now that they now engage and involve as patients in some of their activities which they do. Your work will leave an indelible ink in the patient safety movement. The patient safety charter which has just been launched is another milestone which us as patients we are very proud of and very grateful. Over and above that, in Yabo when we lost our chief executive, you were with us through and through. Up until you even organized the exhibit. We don't take this for granted. We thank you very much and wish you all the success as you now graduate into an advisory position. Otherwise, let me request you to accept this small gift which we have for you. Thank you.
Thank you.
If I could just say a few
Yes.
words. Thank you so much, Dani. It's really a surprise for me, and I'm really honored and very emotional. And thank you so much indeed. I think everybody in this room is a patient advocate. All of us are here because we are committed to patients and their engagement. And when I took over patient safety program, I realized that we can never achieve safer healthcare if we don't have patients with us. So we formalized it through several mechanisms and Global Patient Safety Action Plan and the Rights Charter. And the journey continues. And we have effective strategies, and one of the most important one which was mentioned earlier was that we build capacity of patient advocates so that they can have more and more people speaking for and expecting and demanding safer care. So unless we really demand safety, somehow first do no harm is seen as something given that is like it has to happen. But we have to state the obvious. That the care has to be safer, because with that you can't get trust to even access the healthcare services. So we can never achieve universal health coverage if we don't have safe care. So patient safety and quality really sit at the heart of universal health coverage, and patient organizations, patient representatives, particularly patients and families who've been harmed in healthcare and they've lived experience, but they now have channeled their energies into improving the safety of healthcare around the world, are really the champions and partners in universal health coverage journey. So with that, I really am touched, and I'm so thankful. As you mentioned, Dani, I'm returning from WHO position of patient safety head, but I'm going to work in patient safety, and I'm committed to patient safety and working with patient organizations, because without patients and patient organizations, we can never achieve patient safety. So it's really in the DNA of patient safety, very integral to work together, as Brian mentioned. And I'm so happy to see Brian, because before I was heading the patient safety program for 10 years, I was heading the blood safety program for 15 years in WHO. So I've been with WHO headquarters for 25 years. I joined into early 2000, January 2000 actually. And the blood safety program, World Hemophilia Federation, we learned so much from you and Mark Skinner, and of course from Thalassemia Federation, from Jula as well. So a long journey of really learning from patient organizations. And it was remarkable to see the impact of patient organizations, high-level advocacy, to even creation of the Global AIDS program in WHO and the blood safety program, which was created. The full department and the World Health Day was dedicated to blood safety, and that is when I came to WHO in 2000. So that was entirely the impact of very high-level advocacy coming from patient organizations and really bringing the voice to policy makers at international level. So real impact stories, and several of them. I'm really honored, and thank you so much indeed for this opportunity. Thanks so much.
Thank you very much. I'm going to just run across here. Microphone back. I was actually asked to summarize some takeaways, but we are so vastly over time, and I really want to make sure you all stay and have dinner with us and have time to engage with this fabulous panel of speakers and practitioners, that I might cut it short and just say, we stand before this wonderfully historic moment enabled by everyone in the room, that we have truly enabling conditions before us. But it falls upon us to make sure that not only are those enabling conditions translated and implemented, but they become enabling actions that we all do in our collective, in our collective world that we share, in our corners, at micro and meso and macro levels, in various disease areas, that we capacity build within civil society, but also within governments, and so that we can move forward collaboratively and make universal health coverage the reality that it should be, and that the citizens of the world deserve it to be. With that, I'm going to skip over the rest of the takeaways and go to maybe just some closing remarks. And Danny, I pass the floor to you.
Fair enough. Maybe acknowledge Ia.
Okay, so we will do thanks before we do the next steps. Fair enough. Ia, Bricks, in the corner. What beautiful and fantastic work we encourage everyone to go and have a look. We'll also, of course, take a photo, and it's going to be disseminated on our respective platforms. Since I have the word of thanks, I also thank the participants for being so actively and passionately involved, and those of you online who are still with us, thank you for being there despite not having the food and drink that we had. Thank you to the fantastic panelists for enriching our conversation and elevating our thinking this evening. I would like to thank our three sponsors, Bosch, Boehringer Ingelheim, and CSL Behring for enabling this. As has already been eloquently said in the room, it wouldn't be possible without your support, so thank you so much for making it happen. And of course to the AV and the logistics team for bringing us all together. I think that's the list of thank yous, and of course a warm thank you to my counterpart and your team. It's a pleasure collaborating with you at IAPO, and with that, I now give the floor to you.
And an even bigger thank you to you and Nicola. It's been a pleasure to work with you on this. So one thing before you go, we wanted to highlight, this side event is not just an event. For us, it's a landmark of this conversation that we are holding for the past years about the importance and the value of engaging civil society and patient organizations in health policies. And there is much more to come. So we wanted to quickly go through some possibilities, looking ahead, what we can do together. We invite you to go online and support the resolution. You can use the hashtag I participate for UHC, or you can use whatever hashtags you want, but just for us to create a wave of support for this resolution, because it is a huge moment. I also wanted to highlight the Global Patient Think Tank. This is a group of patient advocates from all over the world. It's convened by Roche, and we have been working for the past 1 year on ways of building the bridge between what's happening locally with regards to UHC, what has been happening globally with regards to UHC, and how we bring this closer to those who are on the ground experiencing UHC. You can learn more about it by scanning this QR code, but I would like to highlight the UHC Compass. This is a tool that we have been drafting and creating together as a group, and this is going to support the patient organizations on the ground to advance UHC on the ground. We are testing some tools, questionnaires, and things that will support the work that they are doing on the ground. And there is a lot of opportunity to for patient organizations to be included in this process. If you scan that QR code, you have access to my email address, but also to Nicola Bedington, the amazing chair of the Global Patient Think Tank. Finally, the Global Patient Movement Catalyst, I'll leave this, Lara has mentioned it already, but I'll leave it for Amanda to highlight it. But again, if you scan the QR code, you learn more about it and you see ways of engaging with it. I'll finish here, and thank you everyone for being here and share, invite Amanda to wrap up and
talk about the patient confidence.
Thank you very much, Danny. On that QR code, we didn't want to overwhelm you with QR codes. You'll find everything that you need to find, whether it's the compass that interests you or the patient movement catalyst or both. It's an invitation to become involved. We are trying to build it from the bottom up, collaboratively, collectively, with all patient organizations globally, regardless of scope, disease area, geography. Come and join us to build this together so that we can ensure we have the capability building, the positioning, and the funding to make sure patient organizations and people with lived experience as experts can design the table, can sit at the table, and can implement the table for all of us. So it's an invitation. Please join us. And with that, we invite you to dinner, which takes place upstairs, and find all of us. And we look forward to continuing this fabulous conversation. So thank you so much for your engagement.